Welcome to Sit and Stay, the podcast that breaks down the challenges of starting and maintaining a mental health practice into digestible chapters. Sit and Stay is presented by RipsyTech, an electronic health record company committed to addressing the mental health crisis in the United States.
Welcome back to the Sit and Stay podcast, brought to you by RipsyTech. I am one of your hosts, RipsyTech Product Manager Parker Anderson, as always, joined by RipsyTech founder and CEO, the festive Tom Tarshis. I actually don't know if that's true or not. Have you started decorating for Christmas already? Or for the holidays, I should say.
Well, and maybe you know this about me, Parker, but we sort of go overboard with the, I wouldn't say overboard, but we do extravagant holiday lights. And so some of those are up, but I will probably be spending 16 hours this weekend or so putting thousands of lights around a couple of trees in front of our house, as I've done for years.
Wow.
Once got in the newspaper for it.
Wow. I did not know this about you. Learn something new every day. I live in an apartment, so I can't quite do that, but I will say I did decorate the apartment for Christmas around the second week of November, maybe first week of November. Went a little early this year.
Yeah, and it will, as you're about to expand your family, the holiday will take on more meaning and it'd be very nice for you coming up. So.
Thank you. Yeah, I'm really looking forward to that. We are already planning out coordinated outfits for next year. So for this week's episode of the Sit and Stay podcast, you mentioned that it would be really great for us to kind of do like a series of multiple episodes to talk about evidence-based medicine in particular. And so this episode is going to serve as a sort of introduction to, what is evidence-based medicine and, just a general overview of how this affects decision-making in your practice. But, before we get into it, anything you want to say about the topic?
Yeah, I mean, this has been my passion and training going back to my public health time at University of Michigan. Back in the mid 90s. And I actually began my graduate school a year after this term came into use. So it was something that I got interested in from the beginning and I've always been an advocate of, and something that's very important and catching up from mental health, but is lagging behind some other disciplines in medicine. So it's you, and I think now you hear it as a buzzword around everything: evidence-based practice, evidence-based medicine. I think it has become somewhat of a buzzword with people saying it, but not really knowing what it means or doing it correctly. And so that's the education process that I try to shed new light on and help so people actually understand what evidence-based medicine is all about.
Well, yeah, let's dive into it. I mean, what is evidence-based medicine? Like, how would you define it? And then, particularly in the context of mental health care, why do you think it's important?
Yeah, so evidence-based medicine is, really at the most basic level, bringing in all of the available research that's been done about a particular topic and then integrating it with patient beliefs, physician beliefs, or provider beliefs, and using that to make decisions about care and treatment for people in need of services. So it's not just the piece of looking at studies on how to treat depression. It's actually understanding all the research and then understanding the limitations of the research, understanding patient values, clinician values, and bring that all together to come up with a logical, rational approach to care for people who need care. And when I'm teaching about evidence-based medicine, Parker, I'll usually ask the doctors or other people in the class, okay, there's evidence-based medicine. If you're not doing evidence-based medicine, what is it called? What is the other type of practice you could just do? So let me ask you that question.
Gut feeling medicine.
Well, and you're pretty accurate, right? So before there was such a thing as evidence-based medicine, you would sort of learn from some other person who had learned from another person, and then you sort of see what people say, and then, but hey, maybe you're like, well, let me try this or that. And there wasn't necessarily rhyme or reason to what people were doing in the treatment provision. And so that's the alternative. And I like your sort of gut feeling term, but that's what we have available.
Interesting. So is evidence-based medicine being used to kind of dictate like new versions of the DSM whenever those come out, or what does the whole landscape kind of look like? Like if I'm a provider and I am trying to best understand how to approach treatment for a specific type of patient, what are the resources that I should be referring to?
That's a great question. And, probably before answering that question, like taking a step back about how the term was first coined in 1992. So it hasn't been around very long. We're talking, 32 years. And, the origins are probably more traced to trying to have some accountability for care that was happening to patients and having a way to evaluate if patients were receiving the best care for a particular illness. And was that spurred on by hospitals or insurance companies, or there's lots of financial incentives as to how everything works. And so it probably came about not necessarily because of the science and this is maybe the right way to do things, but maybe more because of other entities trying to have financial accountability for what was happening with health insurance dollars being spent on treatments. Your comment about the DSM is unlikely to do much with evidence-based medicine, right? This is the group that comes up with our psychiatric diagnoses. It doesn't necessarily have much to do with treatment. A lot of it is that is on some level your gut feeling idea. This is just groups of people sitting around with their knowledge from their lives coming up with criteria for different illnesses. So that is on some levels very gut feeling and non-scientific, which is something we need to be aware about in this field. And I think I always tell my patients, these diagnoses are essentially made up things by, old white men, and maybe I sort of fit into that category now. But so like I don't focus too much on the diagnosis. I focus on these functional measures and are people getting better. That being said, in order to actually do a study to develop some evidence-based practices, we do need a way to classify people. So we do need these diagnostic categories. Otherwise, you would never be able to develop treatments.
Well, to your point about also being an old white man, I guess I would say that, really that represents like, privilege. And in your case, identifying that, you are in that position of privilege, we do need more people such as yourself who are, in that position and willing to think critically about it and say like, hey, this is maybe not the right way of doing things, and, putting things back on the right track. So just going to throw you a little credit there. So for evidence-based medicine, is this something, are you speaking kind of in terms of like general medicine, or is this for mental health care specifically, or, has there been any kind of different way to framing it specific to mental health?
Yeah, I think even you could expand it further, like the general principles of evidence-based practice could really be applied to anything. It could be applied to clean water supplies, to pollution standards, to recycling. And, then there's a list of criteria you run through in evaluating how good the evidence is for every single practice. For everything you do, there could potentially be an evidence-based practice. So for us in mental health, it's really evidence-based medicine and very specific to research on treatments for mental health. And I can sort of run through some of the criteria and how you get to a place to judge the quality of a treatment, and try to do it in a way that it translates well on the podcast, if that would be helpful.
No? Okay. Well, yeah, I mean, how do you evaluate the quality of evidence behind a treatment?
Yeah, so this is a little bit subjective, but in general, we'll group group treatments or practices into different categories. And the categories I like to use are, no evidence, possible evidence, probable evidence, and then gold standard or feeling pretty good. I never say 100%, but so that top category is sort of gold standard evidence. And there are steps in evaluating the research or the treatments or practices you're doing. And these steps have to start with, number one, there has to be some biological plausibility. So in medicine, there has to be some biological plausibility to what you're doing. So you couldn't just say, I'm going to take a rock and hit people in the head, and that helps them fall asleep at night. Well, there is biological plausibility in that, but there has to be a logic and rationale and reason, and the science has to back up what the treatment is. In addition to there being biological plausibility, there needs to be documentation and a manual for what's happening. And I think this is where mental health has struggled a lot, because some of our tools for treatment are very hard to manualize or do exactly the same way, especially if you think about psychotherapy. But we do have manuals for that. So having some biological plausibility, having documented procedures is also important. And then you get to the place where you start looking at the studies that have been done. And our gold standard study is what, Parker?
This feels like a trick question. Gold standard study is...
Well, so the randomized clinical trial.
Oh, yes, of
course. Our gold standard study type. But as you know, we do lots of stuff that there could just be a case series where you see 5 patients and you did X with them and they seem to get better. So you can report that, and that is some research. There could be a study around... Sorry, I got distracted because we're shooting this on the day of this tsunami warning in California. Right. And these warnings keep popping up all over the various electronic devices in the room. So sorry for the pause there. But we have all these different types of research, from a case series to a little pilot study where maybe you have developed a protocol, but you're doing it on just 10 people. Maybe you're doing a more before and after study with the same group of people, but there's no control group. And then you're adding doing a smaller study with the treatment group and control group, and then that's even stronger. But then the strongest of everything is getting up to the place where we have this great new treatment for anxiety. We're going to have 50 people do this treatment and have 50 people either do nothing, do sort of a placebo or fake type, have a fake arm to the study. Or if that's not ethical, you could do, well, we're going to have this other group do a standard cognitive behavioral therapy treatment, and then compare them with this new treatment we developed and see if we have the same results or the new treatment's better. And that's that randomized clinic. And you're going to make sure no one knows which group the people are in, that the ratings are done well, and that we don't introduce complicated sources of bias and other stuff. And there's all these factors around evaluating the quality of studies. So some of those categories I mentioned, like possibly evidence, that would be if there was this lower level of, like a before and after study seemed to work, but it didn't have any randomized clinical trials, that would maybe be in this possible category. If there was one really good study that had great results and there's a manual to it, that might go all the way up to the probably works. But my standard that I like to be at this gold standard is you have a treatment that showed in a randomized clinical trial, it had very good results. And then you take that treatment and it's handed off to people not associated with you, maybe in another country, another setting, and they do the same exact study and they also get the same results. So if you have two independent groups doing the same treatment with good findings, that is in general a gold standard treatment that we can say, okay, we really feel like this treatment works. And within each of these gold standard treatments, you're going to have a percent success rate. So when I'm meeting with my families, when talking about a treatment, say for depression, hey, interpersonal psychotherapy has a 75% success rate, and medications for teenagers have about a 69% success rate. But this is where we can get some of the data to help inform the decisions to present to our patients about treatment. Very complicated, sorry.
No, that's all really interesting, and I'm learning a lot just from listening. You mentioned kind of finding a way to manualize treatment to keep it consistent between patients, between who's performing the treatment. Does kind of like a comorbidity of diagnoses or symptoms ever kind of play into, I don't know if it's as black and white as saying, this person has ADHD and depression, and then this person has just anxiety, has just depression, or this person has depression and anxiety, or this person has anxiety and ADHD. I'm just kind of picking those three and mixing and matching. But, is there ever kind of any like overlap, or saying like, hey, I need to pay attention to this because of this symptom, but also stick with this because of this symptom? I'm just kind of thinking out loud, but does that make sense?
Yeah, and you've sort of hit on one of the biggest flaws with a lot of research, which is the difference, and there's terms for this. So there's efficacy research, which this is where, at Stanford, you design a study and you really get a very limited group of people to be in that study. So the studies will try to target, we're just going to find people with only depression and not anxiety and do this study and then show our outcomes. That's an efficacy research trial. And that's what most of these trials that we get the evidence from are efficacy university studies. However, in the real world, depression is highly comorbid with lots of other things, especially anxiety at 50% more. So do we take this? We know this treatment works really well for depression, but we don't know how well it works for someone with depression and anxiety, or depression and ADHD. The odds of someone walking in with just that one symptom are very unlikely to happen in your practice. And so studies that are able to go out into the community and be a little bit less rigid on that criteria, those are effectiveness studies. And in general, there's a push to do more effectiveness studies so that the results are translatable to the real world.
Yeah.
But it's a very hard thing to pull off, because most of the funding for these studies goes to these university centers and people with lots of expertise. And it's just not set up well to involve people running community clinics in the real world to do some of this research. So this is one of the biggest limitations of evidence-based medicine.
Well, shoot. I kind of want to ask, like, what would you do differently?
I mean,
go ahead.
Yeah, and this is part of the goal. I think it's part of why we developed our own electronic health record. It's why I wanted to build big clinics, was to do some of this real world research and have good access to the data, because I don't see a mechanism to get away from these university studies,
Right.
just deciding best research. But what I would like to do, though, is take some of those findings from those studies and be part of validating them in the real world.
Right.
So, okay, we said this treatment for depression seems to work really well from these university studies. Let's actually see how well it works in these community clinics. So that's what I would like to see happen more.
Well, yeah, stay tuned, dear listener, for developments in that. With
Well,
what
and just to
we might
give
be able to pull off.
There's a very good example of the flaws of gut feeling medicine that went on for years and years and years that I can share. It's from a different field. It's from the field of obstetrics. But for anyone who's had
Obstetrics.
Delivering babies.
Oh, yes. Okay.
So for anyone who's
Should really
had
know
babies or coming up for you, Parker, so a little
Yes.
piece of relevant information. So there's a procedure.
OBGYN. Yeah, I got it.
OBGYN, yeah.
Yeah.
There's a procedure. So I have 5 kids. 3 are older and 2 are younger. But when my older kid, and I'm a physician, and I actually honored my OBGYN rotation years ago. But there's a procedure called an episiotomy, which is where you use a scalpel and use it to widen the vaginal canal when people are concerned that the baby is too big to fit out, or that there might be tears associated during the delivery. And so this happened with my older kids. And it was sort of something that happens in the moment. I was trained on doing it in medical school, and, okay, it sort of seems logical that the baby's stuck. Well, let's just cut the opening a little bit wider. Yeah, we'll have to put in some stitches, et cetera. But, the baby, we got to help that baby. And then, when I was, one of my younger kids was being delivered, the OBGYN, who was a younger doctor as well, said, that had just been going on forever, and no one had ever actually studied if that was a good or a bad thing to be doing these episiotomies. And she said that it turned out that there's really no evidence to be doing this. And in fact, the healing from tears during delivery, if they happen, is much easier for the moms to recover from, much less, bad outcomes and consequences. And so that it was not something that should be happening. And so they don't really do episiotomies anymore. I shouldn't say they don't. Our OB talked about not really doing this procedure anymore because it had never been studied. And finally, some people did a study and showed that, hey, this is way worse for the mom and doesn't actually do anything to save lives or, have a dramatic impact on the babies.
Yeah.
But that is something that went on for a long, long time.
Wow. Okay. So yeah, to your point earlier, that's one of those things that's maybe somebody learned from somebody else who learned from somebody else, and not necessarily taking into account the evidence. So when it comes to making a clinical decision, what how do you balance essentially what you as a provider think should be done based on your own experience and expertise versus what the evidence might be saying versus, and I almost want to say, I guess it is kind of like your gut feeling versus what the research is saying versus maybe what the patient is saying. And, also keeping in mind like what their gut feeling is saying or what their Google University research is saying. Yeah, how do you balance all of that to, find the right way forward?
Yeah, no, and it's a good we'll have more podcasts on AI, and can AI do better at evaluating, options for treatment than physicians can. But regardless of that, the approach I take with my patients is to do the best job possible to come up with a diagnosis, and then provide information as best as possible on any treatment that may have some research to help people get better. And the way, good. So it might be, okay, let's say that you've got a teenager with depression and anxiety. There's some evidence for medicines that can be helpful there. There's some evidence for therapies that can be helpful there. There's some evidence for things like exercise, appropriateness of school fit, or these other social factors. So we'll sort of break it out into this biological, psychological, social intervention where you can list, here's the different things we can try, all which have some evidence, and then have a discussion together on what is the family interested in, what is the patient interested in, and even more important than that, what is, from the knowing the patient, what is going to work and what just is not going to work. And, medicines for kids especially are, I think it's fair to say no parent necessarily wants to put their kids on medication. So that's always an important conversation to have. If we're talking about something like depression and anxiety, we definitely know cognitive behavioral therapy is probably the number one therapy treatment and has very good results. However, it's a very active treatment. It has sort of homework between sessions. You need to have a lot of engagement, and you might be the best, most engaging, skilled cognitive behavioral therapist, but if you've working with someone who just won't challenge their thoughts or who won't do some work in between sessions, then that's a terrible treatment choice because you won't have results there. And maybe you need to switch to a different therapy that may not have as good results, but is just a better fit for your patient. So I think it's that skill set of navigating, presenting information. I try to make it, we're a team working together, and I don't want to be the, years ago, people were taught to never question their doctors, or the doctors were, you do what the doctor says. And, occasionally you'll have a patient that just says, just tell me what to do, whatever you say. And I don't necessarily like to do that because it's got to be this team decision, and that model actually has evidence that it gets better results. So, but yeah, that's how I do it together. Bring all that together with the evidence-based principles when treating patients.
All right, and then that sounds like a like a really good way to overcome a potential barrier with communicating the right way forward with the patient. But what might be some common barriers when it comes to implementing evidence-based medicine, and how might providers be able to overcome those?
Yeah, and so one of the other important pieces that we talked about on other podcasts, but that has to go with the evidence-based research, is you need to have outcome measures that are well validated, so that's part of knowing if a treatment works, right? So if you're working in still in mental health, most people judge their patients getting better by sort of, how are you doing this week? And we are trying to push towards using a little more structured approach to get that information on how your patients are doing. So I still think one of the biggest barriers to evidence-based medicine is having regularly done assessments from both the patient, the clinician, and if there's a third party, so if it's a minor, and the parents, that you look at that data on a regular basis to help balance and evaluate the treatment that's been decided upon. So I think that is the biggest barrier to this entire piece of doing evidence-based practices. So we solve that by using RipsyTech and I'm trying to clean it up a little bit so that we're getting
Yeah.
this sort of monthly data on how our patients are doing. And mental health is less. If you go in for treatment for infection, you get antibiotics. You can look and see the infection's better. In mental health, often we're dealing with, feelings or other less direct functioning measures that are not as easy to just. You can't look inside your brain and say, "Oh, the depression's gone." So that's a specific in our field and another barrier with respect to evidence-based practices in mental health.
Yeah, and I think that's why we have so many different types of approaches to whether that's, multiple types of questionnaires or, doing something like an ecological momentary assessment where it's like random, like here, how are you feeling right now versus like how are you feeling right before your session. Even I just found out on my Apple Health app that they have like their own kind of graph that you can use to keep track of using I saw it was 16 questions and I looked at it and I went, wait a minute, 7 plus 9 is 16. Figured out it was a PHQ-9 GAD7 combo that they put in there. Anyway, yeah, so that's all good. So anything else we wanted to say before we move on to the mental health business moment? And we are going to keep talking about evidence-based medicine for at least another couple episodes, perhaps more. We'll see. But anything else you want to touch on?
Yeah, no, just glad you brought that up. And we'll talk a little bit more about the intricacies of psychotherapy research and psychopharmacology or medication research and talk about some specific treatments. And, I teach a critical thinking class where really there's no research study that can't be torn apart pretty strongly, which is why every research article has a section called limitations at the end, where the good studies will be thoughtful and do a lot of that work for you. But there's a lot of other intricacies there, and so we'll spend more time and delve a little deeper into some specific topics. So that will be exciting.
Yeah, that's always fun. That was I think that was my first big lesson of grad school, was realizing that research is flawed, and sometimes I tell people like that was the biggest thing I learned in grad school, and that those research papers you read in your undergrad could be wrong. And I think most people I tell that to, they go, "Oh my God, you're right. I never realized that."
Yeah.
Anyway, so let's move on to the mental health business moment of the week. What are we dealing with this week?
Yeah, I think it's for people having. We added health insurance to our nonprofit several months ago, so that our employees can get health insurance, and everything's set up on auto pay to come out of the bank account because you don't want to mess around with your employees' health insurance. And then I got an email warning saying your insurance is about to be canceled or you have a grace period and you better pay. And I was quite stressed out because we don't want employees to be without health insurance. And I was very surprised at myself because I feel like I always set up the auto pay or take care of this at the beginning. And I logged into the account, and sure enough, it showed the auto pay was set to come out. And but I called the 800 number and was on hold for 26 minutes or so, and then was able to speak to a person. And they said, "Oh yeah, you're fine. The auto pay set up. You can just ignore those threatening emails." And I said, "Well, it's hard to ignore an email that says all your employees are going to lose their health insurance." And so they didn't have a solution for me around this. But of course, I just went and changed the auto pay date to be 10 days earlier. And then that stopped the warnings from coming. But it's just another example of, a scary moment because you don't want people to lose health insurance, but not the greatest system and warning system. And so that was the moment of the week.
Goodness. Well, yeah, keep us updated. Perhaps episode 2 of Evidence-Based Medicine will be able to provide an update on whether that all worked out. All right. Well, yeah, I hope it does work out. Hard to know what to say to that. All right, Tom, before we wrap up, anything else you'd like to say?
No, thanks, Parker. Yeah, good to be filming again after a couple week break.
Yeah. I feel like we're like getting back into the swing of things because I was gone for a few weeks. So, and our last episode was a guest episode as well. So yeah, I think it's the first time we've really done like a proper recording in maybe 4 weeks. Well, yep. It has been fun. There you have it. Thank you for joining us on this week's episode of the Sit and Stay podcast, brought to you by RipsyTech. If you have any questions and you want to submit them to our audience Q&A, or you're interested in featuring as a guest on the show, shoot us an email at sitandstay@ripsytech.com. All right, Tom, I'll see you later.
Thanks, Parker. See you soon.
Bye.
Thank you for tuning in to this week's episode of the Sit and Stay podcast. Until we meet again, we invite you to sit and stay with the ideas and stories shared today. Dive deeper into how RipsyTech can support your practice by visiting us at ripsytech.com.